Okay, I'm starting my presentation. Shall we proceed, Dr. Bramara?
Give me a second, doctor.
Okay. Good morning, everyone. Today, my topic is navigating the daily clinic and how to align it with evidence-based pediatric care. In this presentation, I will try in a simple way to bridge the gap between the rigid academic guideline and the daily clinic rush. So we all face the same issue. We have 20-minute slot for appointment. This is the average length. And at the same time, we face at every encounter 3 to 4 complaints of different systems, and each complaint with its own complete guideline to reconcile. And in the same visit, we have a family in the room, mother and father, or even sometimes with the grandparents. All of them are expecting a confident, unhurried answer regardless of the time. So in such encounter, within 20 minutes, should we follow guidelines? And which part of the guideline can bend and which must never move? So today, I will talk briefly about a mental model to see what can bend and what cannot. And we'll have some case-by-case clinical pearls that about fever, ear infection, or in a few cases. And the tools that actually save time, red flags that never, it's not negotiable, and some cases. So the mental model that I mentioned, it divides every encounter. So every guideline element, it is one of three. Either the non-negotiable, this is safety critical element and should never be compromised, regardless of the volume of the patients, like the red flags, danger signs, and age-specific risk that we should never compromise, and it is not negotiable. So we can encounter a case fitting into this, and the guideline that never compromise, and it is not negotiable, it fits in this. The other type, it can be compressed, like counseling depth, documentation details, and discussion length can be shortened without losing clinical safety. It is conditional on clinical judgment and context. And every encounter, not every encounter, some encounters, we can save time by delegation, like screening administration, taking questions, educational handouts, can be shifted to staff if possible, or portals. We have a wonderful portal, we have a wonderful EMR and application. We can get the maximum benefit of it by delegating some screening tools and send it to the patients, to the parents, to go through it before coming to the clinic. So it is operational layer and can be delivered. So now, fever without a source. Here, the guideline says you stratify by age with distinct lab, an investigation, and admission criteria. So there are multiple decision trees. If you take the American Academy guideline for managing fever without source in infants below 60 days, there are multiple algorithms according to the age, and each one of them lists the decision boxes and how to go through them. But in reality, anxious family, same day walk-in slots and decision needed before the next patient in the room. Lab may need same time and are not always instant in the clinic. So this is the reality. So we don't have all the time lab available, and we don't have all the time the fast tests, the POC, and at the same time we are facing an anxious family, and they expect us to manage everything perfectly. The pearl here that we have to distinguish the cutoff and ill-appearing criteria. This is not negotiable. So when we encounter such cases, the non-negotiable part of it is the ill-appearing and exceeding the limit of normal for this age. Using a printed age-based algorithm to guide our practice, this can shorten the time and can save us some time to take the decision. And pre-arrange a rapid referral pathway for infants who need urgent workup. So here, how to align, this slide shows you how to align the guideline in your clinic when you are in the clinic providing the primary care for pediatrics, and you have a guideline discussing nicely how to manage infants with fever. But if the patient is not ill-appearing, if the child is well-looking, his vitals are within normal, this is very simple. But if you encounter such case, within 20 minutes, you have to manage this child, and you have to stick to the guideline, and you never deviate from the non-negotiable part. Talking about otitis media and how to align the guideline in the management of acute otitis media in the clinic. What the guideline says, watchful waiting is appropriate for 6 months to 2 years, non-severe unilateral cases, and most of children above the age of 2, they can manage by watchful waiting. The guideline also it requires a reliable follow-up and a clear understanding from the parents of the warning signs. But the reality, parents, when they step in our clinic, they are expecting, they come with the diagnosis first. They diagnose their child as otitis media, and they expect us to give them the prescription of antibiotic, and they will take it, and they might not come back for follow-up. And again, the reality shows us that conversation is sometimes compete with a packed schedule. Like, if we want to convince the parents about the watchful waiting and tell them there is no need for antibiotic, discussion with parents in such cases, it might take long time, more than 20 minutes. If we don't have a list of queue of the patients waiting, that's fine. We will spend the time for that. But if the queue is long and multiple patients are waiting, so this is challenging to keep going in this conversation and send them with the appropriate management plan as per the guideline. So the pearl, how to manage this? Here, the non-negotiable part of the guideline is if severe symptoms, bilateral disease in young infant, or otorrhea, these fits the criteria, the need for the antibiotic. But other cases from 6 to 2 and above 2, if the watchful waiting is the plan of the management, here we need to maybe think about a ready script to deliver the information for parents in a nice way to convince them that most ear infection clear on their own, and here how I will watch it together, how we will watch it together. You have to give them plan to come back, and you have to enlist this plan by steps to make it easy for them to understand. And you can send home a printed safety net prescription with a clear return precaution instead of long verbal discussion. So here, where you need to go directly for antibiotic without long discussion, and how to manage such cases without prescription, yet at the same time you are saving the time in the clinic. Let's take a bronchiolitis. What the guidelines say is that no routine chest X-ray, no bronchodilator, no viral testing for typical presentation, and supportive care and a clear return precaution are the core recommendation. Reality comes in our clinic within 20 minutes. Parents are requesting for the chest X-ray, and they discuss and argue with us why you haven't requested the chest X-ray. And they see their child is wheezing, but at the same time the child is happy. So how to manage this? The guideline is very clear. There is non-negotiable part when the child is having hypoxia, apnea, or remarkable distress. This definitely will trigger escalation regardless of other things. But in such case, it is the harder skill is the pushback conversation, not the medicine. Here, our problem is not the antibiotic. Our problem is not the medication. Our problem, how to tell the parents your child is currently stable, fine, can be sent home to be observed with normal saline only management for the nose, nasal secretion. You have to deliver it in a way not to consume time, not to take long time, and deliver it in a way easy for the parents. Again, one of the challenges in the clinic, it is the anticipatory guidance. Bright Future from the American Academy of Pediatrics outlines a comprehensive checklist across nutrition, safety, development, behavior at every visit, designed to be covered thoroughly at each well-child encounter. Again, 20 minutes visits cannot deliver the full checklist in verbal form, especially with a squirming toddler. And something usually gets rushed or skipped without a plan for what. So here, in the 20 minutes again, you have to do to go through all the checklists for the well child, and you have to have clear cutoff, clear non-negotiable parts, which comes to the safety topics and milestones, red flags. These are non-negotiable. You can find from the Queen's Children's Hospital a clear, nice table about the red flags for each age, and it will guide you to go directly to the red flags. You can shorten the time for, instead of going for full detailed checklist, you can directly go to the red flags. You ask about them. They are not present, then this is major part is accomplished already. And again, we can use our portal, our application, or even the email and EMR system. We can send the checklists for well children, well baby. We can send it to the parents. They go through the checklist at home. They come us to the clinic. They come here to the clinic to discuss with us the result. And by this, we will shorten the time consumption and will make it enough for 20 minutes to be fruitful visit, to give the maximum advantage for screening our children. So we can delegate for pre-visit handouts or portals for age-specific guidance. We can compress everything like 2 to 3 guidance topics relevant to the child age and risk. But again, non-negotiable part is the safety topics and milestones, red flag. So you see in the slides mentioning the title and where to avoid skipping the non-negotiable part and where you can delegate and reduce the effort to make everything fitting into 20 minutes. Again, the MCHAT and ASQ in practice, the screening for the autism, full standardized administration of scoring takes a big chunk of the 20 minutes. So it's 20 minutes is not enough for such screening. And it's designed to be completed attentively, ideally without interruption. But in reality, scoring during the visit competes directly with everything else on the agenda. So what we can do here, we can send it ahead of time to the parents who are coming in the age-appropriate time for screening. We can send it to the parents through the email. We can send it through our EMR, our portal, patient portal, and they can fill it and bring it to us to do our conclusion. And keeping in mind, the non-negotiable part is any positive screen that has to be discussed. So this is regarding the MCHAT and ASQ screening for autism. The DSM-5 criteria and Vanderbilt scales for ADHD and inattentive children, the guideline says that this screening score has to be given to the parents and the school teachers, and you have to have the feedback from them. And full diagnostic process typically spans multiple data sources and visits. But the reality, families often want an answer today. They don't want to keep coming for visits and collect information every time. So non-negotiable that never diagnose without full criteria. And we can delegate, we can send these scales, we can send it home, take it with you, come back next week, we will discuss the scales. And you can give another copy for the teacher to fill and bring it with them next visit, and we can discuss the result of that. But within 20 minutes, you cannot do the scoring because it needs full attention without interruption. Again, quickly, like regarding the antibiotic stewardship, guidelines said avoid antibiotic for uncomplicated viral infection, upper respiratory infection, but the reality, parents expect a prescription to leave without something. Sorry, to leave with something. We have to say it, we have to prepare a phrase that to clearly and nicely deliver the information, and we have shared decision about the case. Growth and BMI counseling. So growth chart. So reality is that growth review is fast. A meaningful conversation is not. So when you have a growth chart, this is important, definitely. But there are other charts regarding the BMI, regarding charts for the preterm. They all require special charts. These can be either sent ahead of time, or they can fill it while they are waiting to avoid wasting the time inside the clinic. Because imagine an ex-preterm coming to you at age of 2 months. You want to they are coming for vaccination. Still, the same time you need to discuss the growth. Still, the same time you need to compare it to the fetal life weight, the corrected age, and discuss all the prematurity within 20 minutes. So we try as much as we can to compress the time, to reduce the time you required for discussing something can be done ahead of time. And again, referral threshold. The guideline refer per specific specialty criteria. Reality, there is a practice in the primary care that refer just to be safe. So this refer to be safe referral habit overloads subspecialty cues. So we should have a clear criteria when to refer. It is really surprising that some clinics they refer constipation to GI every time. So constipation is a common general pediatrics case and can be managed. No need to keep referring them unless there are red flags in the constipation. So the things that can save time, you can have decision aids, laminated cards like for red flags, you can have them with you. Laminated cards for cutoff for the ages in cases of emergency, same as the BLS, PULSE algorithms. Uh, and so pre-visit intake tools, like we can share with parents the QR screen to screen before coming to fill the forms and bring it with them. We can have order set and a standing protocol, like for example, the case who are coming for the triage and the nursing station, case of abdominal pain, we need to do either glucose check and urine dip while they are waiting. So during the rush time, doing such protocol, it saves the time in the clinic and it saves time for the next patient also. So we need to adopt such protocols. And the scripted pushback language, we need to practice that within seconds, certain phrases, why no antibiotic, instead of giving, no, I will not give you antibiotic. No, we started with why there is no need for antibiotic in such cases, because of 1, 2, 3, in very simple words and shortly. So where speed is not an option, so it is in the non-negotiable side. Regardless of the volume, regardless of the time, any ill-appearing infant or any infant less than 28 days with fever, bilateral otitis media in infant or otorrhea, positive developmental or safety screen of any kind, signs of distress, lethargy, dehydration, altered mental status, any finding that does not fit the expected clinical picture. So these are non-negotiable, whatever is the time, whatever is the rush in the clinic. Here, unfortunately, technology let me down. I wanted to use a live poll to put the answer, but I will use the interactive screen right now instead of the application. So let's have a case. 10-week-old boy with 2 days of coryza, now with cough, wheeze, and mild chest retraction. He's feeding well, more than 70% the usual volume, oxygen saturation 39 in room air. What is the most appropriate action? Can we have like from the audience? So is it to admit any bronchiolitis under 3 months? Start oral antibiotic for possible secondary bacterial infection, manage at home with safety netting advices, no admission criteria are met, or to order chest X-ray to confirm the diagnosis. Any answer? Any volunteer?
B, manage at home with safety
Yes,
netting
exactly.
advice.
Manage at home with safety netting advice, no admission criteria are met. Admission criteria is saturation below 92, ill-looking, the child is not feeding, dehydration, and the need for oxygen. These are the criteria for admission. So this can be managed at home, can be managed at home, but we have to give the parents a management plan clearly identifying when to come back and what they have to do, and give them an easy access to help if we are not present, which fortunately we have the telephone call, but problem sometimes delay in response. So in cases of acute otitis media, so 3-year-old girl has 24 hours of ear pain and fever. Exam shows a bulging tympanic membrane, no perforation or discharge. She's alert, well hydrated, and otherwise well. So the decision, so immediate antibiotic prescription, bulging tympanic membrane confirms bacterial infection, or no antibiotic or a backup prescription, plus an analgesia and safety netting advice. Refer to ENT topical antibiotic ear drops at first line. What the guidelines say here, what is the answer? So I don't want to waste your time. So the guidelines say here, B, the answer is B, no antibiotic, and she needs analgesia for at least 48 to 72 hours with safety netting advices. So again, cases of antibiotic, here discussion in the clinic will be, why I want antibiotic, my child is having fever, my child is having ear pain. So we have to deliver the information in a short sentence, and in order not to consume long discussion and consume long time in discussion in the day where we have long queue. We have to know, and there are no criteria for prescription antibiotic. So there is no oturia, the child is not ill looking, the child is well hydrated, alert, and otherwise well. So these are not the criteria for antibiotic. So the expected management is the right answer in such case. So this case is based on the NICE guideline for traffic light. So 4-month-old girl has had fever of 39.3 for a day. She is alert, feeding normally, with normal color and no rash. Respiratory rate 38, capillary refill is below 2 seconds. So what is the risk category in such patients? Is it low risk to manage at home? Is it intermediate risk, needs assessment? High risk, needs urgent referral? Or cannot classify without urine sample first? Here, do we have any answer? Here,
I think it's between, yeah. Since she's 4 months old,
Yes.
she falls under the intermediate risk, and she's got high grade fever, although she's alert and feeding well.
Yes.
We
So
would not be able to classify without.
Here, this is an intermediate risk and needs assessment.
Yeah.
And the answer can be also B, D. So it's not like you cannot classify. It is intermediate, but clinical guideline, it gives you the chance to test the urine sample also in such case, instead of sending the patient home. So you have to check about the urine because no other symptoms. So it is intermediate risk that's correct and needs face-to-face assessment. 4-month-old girl has her first febrile UTI. It's E. coli, and she responds well to oral antibiotic within 48 hours and is now clinically well. So what is the next step? No imaging needed. She responded well to treatment. Ultrasound within 6 weeks, ultrasound during the acute phase plus DMSA scan at 4 to 6 months, or MCUG only. Here, there is nice guideline. There is American Academy of Pediatric guideline for UTI, but the most recent is the NICE. American Academy, I believe it is not updated since long time. So in this case, this is the first UTI, and it is typical.
Ultrasound within 6 weeks.
It is what?
Ultrasound within 6 weeks. Actually, 6 weeks is a long time.
This is UTI, first attack, and it is typical organism E. coli, and responded within 48 hours. And clinically, she's well right now. So this fits into B, ultrasound within 6 weeks. So this is the guideline. So this needs to be structured and delivered to the parents in a proper way. So no need to go for extensive investigation, definitely, because no criteria are met. So bringing it back to the model, every guideline element you meet in the clinic sorts into one of 3 categories. Non-negotiable, where the red flags, age cutoff, and full diagnostic criteria are needed before the treatment. The compressible, where the counseling depth, documentation details, and discussion length that can be shortened according to the day. And you can sometimes delegate part of the guideline for the parents ahead of time before, or they do it while waiting before coming inside the clinic, like screening, administration, questions, and pre-visit education. So the take-home messages, guidelines are not the enemy. The volume mismatch is the real problem, not the evidence itself. We have to protect the non-negotiable, like red flags, diagnostic criteria. And we have to to manage our workflow, and if there are certain things can be delegated, and to reduce the time consumption during the 20-minute slot for the consultation, like screening tools and educational part. And we can use certain protocols like screening patients who are coming with fever and abdominal pain, or abdominal pain itself alone. We can screen them before they come to the clinic for glucose and urine depth. So thank you so much. Thank you for the work you do in the clinic every single day. And it's time for the discussion and questions. Please, if you have a question, unmute yourself.
Thank you so very much, Dr. Hurani, for bringing in a very important aspect of our clinical practice. Actually, I see a lot of offshoots from this presentation that can help all of us minimize waiting time, improve patient experience, and increase the depth of our quality. To to begin with, I very much like your the whole concept of bringing an evidence-based approach to clinical practice. The things that I wanted to share was, while they're waiting in the waiting area, if you're able to get them to do a pre-questionnaire or symptom check, that can be with the help of IT, either get to the nurses in the triad section or also to the doctors, especially also to the doctors. So if this data can be captured, this will really save a lot of time asking questions, repeating. The triage nurse asks the same questions, a few screening questions, and then as doctors, we repeat the same. So that is one. So a symptom check that they can do. The same thing can be also extrapolated to vaccinations. Now that the NHRA requires, the Ministry of Health requires a pre-vaccination checkup to be done. That includes a lot of questions, at least about 15-20 questions. So that that also can be done in the waiting area, or when the person takes an appointment takes an online appointment, it should just flag up there, and then they can complete the pre-vaccination assessment at home, sitting at home. So even as they take an appointment, whether it is at home online, they can address these pre-visit questionnaire, or sitting in the waiting area. This, I think, if we are able to translate into execution, that will be brilliant. In order to, it will reduce our waiting times drastically.
Yes, exactly. So here we need to computerize, we need to plan having this to reduce time and to complete the care of our patients. Yeah, I agree 100%.
And the second offshoot is about the handouts that we can actually pre-design and keep, rather than spend time in explaining all the red flags. So if we can have some handouts for common symptoms, like we have for fever, acute otitis media, or bronchiolitis, for diarrhea, for all of this, if we can have some pre-designed handouts that we can just hand out for that specific condition, and it's standardized. It's across the board, across all of ARMS. We have the same standardized red flags mentioned there. That will help in safety netting as well. And that will certainly decrease our discussion time and patient education time.
Thank you. Any other comment, any other question from the audience? So shall we close the session today?
1 second, 1 minute, 1 minute. Before we close, this is from now on, there will be some of our CMEs that are accredited with CME points. And the current presentation is accredited. So in order for us to capture the attendance, it's very important that we name, when we log in to the Zoom meeting, we put in our actual name along with our employee ID. This back in from the Zoom, we'll be able to get the attendance sheet. In addition to this, each one of us sitting in different units will have to also manually sign the manual attendance sheet that needs to be sent to Freedom by the respective unit in charges, right? So this is one thing you need to take, so that they can then add the CME point to your account. Yeah. So those of you who have not named yourself correctly or have not put in your ID, employee ID, please do that before we close this meeting. Any other comments, any other questions? I have one question. I'm just curious to know, how come you picked up this topic? It's a non-clinical topic as such. It's more to do with clinical, yes, because you have all these guidelines. But then, how did you come across this topic, which is quite.
It is one of the common clinical cases. One of the common clinical areas where the evidence hasn't shed light on it. I use the AI to choose the topic and see, like, we can find the guideline for the clinical topics everywhere. I used the AI to see where in the daily clinic where the guideline hasn't shed light and didn't give it a proper illustration. And I myself was surprised about the topic was chosen, and that's how AI is helpful in my presentation. And I used it to design certain slides. Yeah.
And what was the prompt you gave for the AI to select your topic? What is the prompt you gave? I know we can have this conversation apart from this. It may not be relevant.
I have to go back to the beginning of my discussion with
Okay.
I will share it with you later.
This will help. I mean, this will help each one of us who has to give, who are enlisted there to give CMEs. So it will ease it out. Ease it out a lot. That's fine.
Yeah.
I think that's it then. Thank you again very much, Dr. Hurani, for this interesting topic that will really translate into our clinical practice. So a copy of this will be posted in the YouTube link will be posted. If you can also post your presentation slides in the group, that will be useful. Thank you very much. Have a great day.